My name is Rolf Stohel, and I'm introducing Dr. Alejandro Navarro from the Hospital Clinic Barcelona, the true implication of small cell lung cancer biology.
So I'm really grateful to be here. Thanks, Charo, Luis, and Delvis for the kind invitation. I'm going to talk with Dr. Adeo about the ugly duckling, about the small cell lung cancer, and I will try in the next 15 minutes to summarize how the biology has an impact in this disease. Here is my conflict of interest. I would like to start with something that is really obvious, for sure, but I think sometimes as a community, the oncologists, we only believe in targeted therapies or in molecular biology, and this is a particular disease. I think that we must to consider when we see a patient with small cell lung cancer, that this is a particular patient with comorbidities, with poor ECOG performance status, higher rate of CNS metastasis since the beginning, since the diagnosis of the disease, high tumor burden, patients with rapid clinical progressions. We must start treatment as soon as possible. This is also important to consider that sometimes, in the majority of cases, the diagnosis is established with small biopsies, with cytologies, with echobroncoscopy. We have to consider always when we analyze one study of biology in small cell lung cancer that there is a selection bias. Patients with more biopsies, with rebiopsies, are patients with better performance status. Patients with poor performance status are not rebiopsies, for sure. And finally, we don't know anything about the disease at the moment of the relapse. I think this is very important that us, as a community, this is how we see a patient with lung adenocarcinoma. In our mind, we have a patient with lung adenocarcinoma, and this is the photo. And this is the photo when we see a patient with small cell lung cancer. We must to consider this, that there is, despite significant efforts to analyze the genomic profile of small cell lung cancer, we know that there is no driver oncogene, this is for sure. We know that this disease is driven by the loss of function of TP53 and RB1. We also know that there is one of the tumors with higher tumor mutational burden due to the tobacco exposure, but on the contrast, this is a tumor with low PD-L1 expression, being around 10% of the tumor samples expressing PD-L1 1 or more, and something that is really, really crucial to understand the poor efficacy when considering the expectations we had in the beginning is the crucial role of the tumor microenvironment that has an immunosuppressive role in this disease. The early beginnings of immunotherapy were for sure first the combination of chemotherapy plus ipilimumab in the first-line setting. This is a negative study, and then the wave of anti-PD-1, PD-L1 arrived for every tumor type, and for sure also for small cell lung cancer. We have these two relevant phase 1-2 studies, the Checkmate 032 and the Keynote 028 and 158, that evaluate the role of the first one, nivolumab plus minus ipilimumab, the second one, pembrolizumab, in pretreated population. And what you can see is that overall, both strategies, nivolumab and pembrolizumab, offers poor control of the disease, but we have a plateau. We have some patients, around 15% of patients that respond, and the responses lasted significantly in this pretreated population around 24 months. Well, let's go to start the search for biomarkers. At that moment, in 2018 or so, the TMB was one of the top biomarkers for immunotherapy. So let's check how it's doing immunotherapy with the combination of nivo-ipi in this trial. We saw at the beginning that patients with high TMB value could achieve a more pronounced benefit of the combination of nivolumab, ipilimumab, for both overall response rate and overall survival. But when we had the more mature data, we finally saw that there was no predictive role for TMB in this particular trial. And the same occurred for PD-L1 in the same trial. Few proportion of patients expressing PD-L1 and no significant differences between PD-L1 positive or negative population. But the tsunami of chemo-IO was established for non-small cell lung cancer, and when considering this data, the evaluation of PD-L1 in the first line was considered. So we have several pivotal phase 3 studies. These three are probably the main phase 3 trials, two of them positive, the Keynote 604 negative, already known for you. In Power 133 and Caspian evaluate the role of the addition of atezolizumab and durvalumab respectively, and both are positive trials, numerically positive, increase of around 3 months of overall survival, and which is really most important is the proportion of patients that achieve a long-term durable control of the disease. You can see as the proportion of patients alive at 3 years is almost the triple when compared with patients who receive only chemotherapy. Let's check for biomarkers again in the first-line setting. We have done several important efforts. PD-L1 is not predictive, TMB is not predictive. We have some signatures that have a prognostic role. We have also clinical biomarkers, ECOG, disease burden, LDH, that has been proven to be prognostic, but again, we don't have any predictive biomarker for immunotherapy. Coming back again to one of the first slides, we must consider that the tumor microenvironment is key in this particular disease. This is a cold phenotype tumor that has a low tumor-infiltrating lymphocytes, high immunosuppressive molecular expression, like for example B7H3, and there is an abundance of Tregs in the stroma. Let's check how combinations with immunotherapy, classical anti-PD-1, PD-L1 plus other agents could turn cold tumors into a hot phenotype. So we have, I will mention only 3 different strategies. One of the most promising was the inhibition of TIGIT. You know the story of TIGIT. 5 years ago or so, we were really happy to have the TIGIT compound in the scenario of lung cancer and also in small cell lung cancer. There were some relevant preclinical evidence that the co-inhibition of TIGIT plus PD-L1 could have really a synergistic effect. But yeah, we have 2 main phase 3 studies that are absolutely negative. Last year was presented in ASCO and also published in JCO by Charles Radin, the Skyscraper 02. This trial was built on the backbone of Empower 133. So patients receive carboplatin etoposide plus atezolizumab plus minus tiragolumab with the maintenance phase of atezolizumab plus minus tiragolumab. Double-blind study, phase 3, and as you can see, this is an absolutely negative study. The same, most recently communicated, most recently shared, the information of the K5-008 study was presented by Jacob Sands in the SITC Congress. The combination of pembrolizumab plus vibostolimab was analyzed and compared to atezolizumab. This is a double-blind study, so patients received chemo-IO. The IO was blinded, atezolizumab or the co-formulation of pembro plus the anti-TIGIT compound from MSD, and a maintenance phase of atezolizumab versus the compound of anti-TIGIT pembrolizumab. You can see the graph, the study is absolutely negative. Even atezolizumab performs better than the combo of anti-TIGIT plus pembrolizumab. So, my opinion, and I think you agree, the TIGIT story has absolutely ended. We have other quite controversial story, which is the fucosyl-GN1 study. Fucosyl-GN1 is a molecule, it's a ganglioside that is overexpressed in small cell lung cancer tumors and that is absent in normal tissues. We have the BMS has developed a first-in-class monoclonal antibody that is BMS 986012. This compound has been tested in 2 phase 1 studies. One phase 1 study evaluating the combination of this drug plus nivolumab in pretreated patients, and other phase 1 study combined with chemotherapy in the first-line setting. Due to the good safety profile and the rationale, the company developed this phase 2 randomized study communicated last ESMO Congress. Here, the immunotherapy is not atezolizumab or durvalumab, it's nivolumab combined with the fucosyl-GN1, and the maintenance maintenance phase, fucosyl-GN1 plus nivolumab versus nivolumab alone. The results are quite so-so, in my opinion. You can see the graph. There is no correlation. This is an important point. Fucosyl-GN1 levels has been analyzed in this trial, and there is no correlation between higher expression of fucosyl-GN1 and higher response or higher benefit to the drug. But the numerical differences in overall survival that you can see in the graph support, according to the company, the conduction of a phase 3 randomized pivotal study, the TIGOS study, that will be conducted. This phase 3 study randomized patients to chemotherapy plus atezolizumab versus chemotherapy plus the co-formulation of nivolumab plus the fucosyl-GN1 antibody. Third, lurbinectidine. As you all know, lurbinectidine is a synthetic marine-derived drug, analog of trabectedin with a complex mechanism of action. One of the key points here is that lurbinectidine acts over the tumor microenvironment, inhibiting the tumor-associated macrophages, making for this reason a good partner with immunotherapy. We have two Spanish important studies, phase 1-2 studies in pretreated patients. The LUPER study, communicated by Antonio Calles last ESMO Congress 2023. In this trial, patients previously treated with only chemotherapy were treated as second-line therapy with lurbinectidine plus pembrolizumab. You can see the waterfall plot. You can see that the combination is active, and there are a proportion of patients with durable responses. We have also the two small study presented by Santi Ponce several years ago, and co-author also Luis Pazares. This important study evaluates the combination of atezolizumab plus lurbinectidine in both patients pretreated with immunotherapy or immunotherapy naive. This study is the main backbone for the INFORTE study. The INFORTE study, as you know, is a trial that evaluates the role of lurbinectidine added to atezolizumab in the maintenance setting. So patients receive the IMpower 133 schedule and then are randomized to lurbi plus atezolizumab versus atezolizumab alone. This is a study that we know the press release that is positive for the two co-primary endpoints, PFS and OS, and probably will be communicated soon in next Congress. Let's talk in a few minutes about transcriptomics. This is a very, very complex part of the biology of small cell lung cancer. I think it's important to mention all the big effort that Charles Rudin and colleagues made in the field. So genomics is not helping in small cell lung cancer. Let's go to check the transcriptomic profiling, analyzing how the predominant transcription factors we are able to customize into 4 different subtypes. And this is a great effort. If we are able to understand the different 4 transcriptomical subtypes, and we understand which are the key predominant factors that have a role for every particular subtype, we can exploit the potential vulnerabilities. But for sure, transcriptomic profiling is not affordable in the daily practice. Briefly mention that we have the data over the SCLC the immunotherapy profile. This is a particular transcriptomic profile in which the benefit of immunotherapy was really proven. We have the data from the IMpower 133. You know that the benefit was higher in this particular subtype. We have also, for the SCLC-A, the potential role of SLFN11. SLFN11 is a DNA-RNA helicase that is overexpressed in around 50% of cases with small cell lung cancer. We have preclinical evidence that the mutations in SLFN11 are associated to PARP inhibitor sensitivity, and we have the trial published by Katy Pietanza several years ago that demonstrated the role of the addition of beliparib to temozolomide for patients with SLFN11 mutated tumors. We have also the important study conducted by the Southwestern Oncology Group in America. In this trial, patients received 4 cycles of induction chemo-IO, and then patients with SLFN11 positive tumors were randomized to atezolizumab versus the combo of atezolizumab plus the PARP inhibitor. This is a trial that met the primary endpoint of improving PFS, but the graph is saying that it's absolutely insufficient and is not a standard of care. Finally, we have also the potential of MYC. We have the alterations in MYC in those particular transcriptomical subgroup, A and N. And we already know this trial published several years ago by Taufiko Wunikoko, where the patients received second line with paclitaxel plus minus alisertib, and for patients with semic immunohistochemistry overexpression, there was a trend towards a greater benefit. Unfortunately, the combination has not been further studied. Finally, in a minute, I would like to mention this complexity of the biology. This is a very, very complex important work published by the group of Julie George last year in Nature. 160 tumor samples from 65 patients, deep comprehensive analysis, including whole exome, genomic, and transcriptomic profiling. And the key message here is that the treatment-naive small cell lung cancer samples exhibit clonal homogeneity at distinct tumor sites, and after the pressure of treatment, there are this clonal diversity. TP53 and ERB1 alterations are exclusively part of the common ancestors, and MYC family amplifications only appear when the tumor progresses, are not constituents of the founder clone. Importantly, the DNA methylation is also an important pathway to consider. The group of Lauren Byers published last year in Cancer Cell this analysis of DNA methylation in both tumors and plasma samples, and the DNA methylation pattern is correlated with the different transcriptomic profiling, and this is important to mention that under the pressure of treatment there is a shift from a neuroendocrine low subtype to from a neuroendocrine subtype to a neuroendocrine low subtype. Importantly, a few days ago, the group of Han in Korea has published this case report. This case report evaluating the analysis, the rebiopsy in a patient treated with tarlatamab. This is a single case for sure, but I think this is important. Tarlatamab, Alfredo Adeo will explain after me for sure about this promising drug. In this particular patient, he was treated with 2 prior lines, and then tarlatamab as third line presented a response, a deep response that lasted for around 1 year and then progressed. So the investigator rebiopsied the patient and conducted encounter assay to evaluate transcriptomical changes after tarlatamab treatment, and what was seen is that 1, there were no genomic alteration, and there was this trend from SCLC A and N towards predominant transcriptomic profiling with P and I, making this tumor more inflamed and probably more suitable to receive benefit after immunotherapy. This is my light slide. Biology of small cell lung cancer is very, very complex. There is absolutely, in my opinion, no hope to find genomic alterations that can be targeted, as we think in a patient with lung adenocarcinoma. There are no predictive biomarkers of response to immunotherapy. Every patient must be treated with standard chemo-IO. This is the never-ending story of transcriptomic profiling. This is not implementable in the daily practice. There are a lot of limitations that make this approach impossible to be used in the daily practice. We have important challenges when we consider the biology of small cell lung cancer. We must take into account the heterogeneity and the plasticity. I think there is an opportunity to evaluate the role of rechallenge with chemo-IO in patients who receive drug that shift the phenotype from neuroendocrine high to a neuroendocrine low phenotype. And finally, we have this promising treatment like DLL3 T-cell engagers and B7H3 antibody-drug conjugates that must be combined with SOC and used as early as possible to avoid the attrition, to avoid the loss of patients. Probably maintenance after induction and consolidation after chemoradiation could be the perfect scenario. And that's all. Thank you.